usually when I work with somebody new, I have to educate them about food addiction, right? Because they will say, well, you could just have a little bit of this only sometimes. And I say, look, for me, like, you've got to be really specific. How much of what should I have when? And like, can it be every day? Or if not every day, then can it be 3 times a week? And that's how I work, because I need the structure, right? I just have that. And I really honestly believe it's not a psychological thing. It's a form of neurodivergence for me.
I was
That's
just
my
about to,
experience.
I
Yeah.
literally was just about to ask you, I was like, do you
Yeah.
identify as neurodivergent as well? And it's like our mind just works
Yes.
differently.
Yes. And I say that because I don't have any sort of neurodivergent diagnoses, but I firmly believe my lived experience of addiction and complex trauma is that I'm neurodivergent because of those two conditions, even though I might not be autistic, maybe I don't have ADHD or whatever else there is. But I firmly believe that addiction, in my case, because I've had it for so long or forever, maybe it's a neurodivergent thing. It's like I can do therapy until the cows come home, but these are some structures that I need to address through lifestyle, not through therapy. It's not psychological.
I am so delighted to introduce to you my special guest for today, Vanessa Kredler. She is a gem of a human. She is a clinical counselor registered with the Psychotherapy and Counseling Federation of Australia. She has lived experience and takes a compassionate and curious approach to working with her clients. She has a focus on addiction, complex trauma, and the intergenerational nature of trauma. Her special area is ultra-processed food addiction, because that was the first addiction that forced her into recovery. Her approach is trauma-informed, person-centered, and informed by internal family systems. She has a master's in counseling and is a certified food addiction counselor by Infact School, and is a level 2 trained internal family systems and polyvagal informed therapist. She also draws on her own recovery journey, somatic, and other healing modalities. And she's a passionate advocate for raising awareness of ultra-processed food addiction and complex trauma and breaking the associated stigmas. Without further ado, I am delighted to introduce to you Vanessa Kredler. Thank you so much for being here, Vanessa.
Thank you. Thanks for having me.
I would like to start with your personal journey. I know that you're very passionate about food addiction. Not everyone even knows what that even is. So I'd love to hear a little bit more about your personal journey, what inspired you to specialize in counseling and psychotherapy for food addiction and trauma, and like got you into this world.
Yes, I'm sure you are not hearing this for the first time, but I have lived experience of food addiction, and I always say I think I've always had it. I might have been born with it. If not, then it started in early infancy for me, and it started initially with just sort of always being really switched on around food, just wanting more and always overeating on a daily basis, and just always wanting, always scanning for food and stealing my
Mm.
siblings' sweets and all of those things. And then eventually it turned into binging gradually. And I remember a very distinct time, age 11, when somebody in my family said, you're going to have to watch what you eat. You're eating too much. You're going to gain weight. And so it was that time, when as a young girl in the beginning of puberty, I was becoming more sensitized around what people think and feel and say about people's bodies, and
Hmm.
so I essentially then, on top of my food addiction, developed an eating disorder. Like, I definitely had a food addiction first, where I was just wanting to eat all the time, and an eating disorder came on top of that because I became very aware of my body, of my weight, wanting to lose weight, trying to somehow compensate for the overeating that I couldn't stop with behaviors, eating disordered behaviors. That kind of continued. It escalated in my 30s, particularly when I had a period of my life where there was a lot going on, a lot of different changes that were happening in my life. And I was really getting quite desperate mentally and physically. So I was gaining a lot of weight quite rapidly at that time. And I was binging a lot at that time. And I was sort of mentally very distraught, just very scared of what was happening with me. And I was worried about going insane, literally, because I had so much food noise in my
Yeah.
mind. And so I sought help. And I was living in France at the time, and I was sort of not, super fluent in French at that point and was worried. And then eventually I ended up with an American counselor who was operating through the American church. And then that was sort of helpful, but she eventually sent me to Overeaters Anonymous, and I sort of started a whole journey of recovery there, and built up, gradually like a support network, and ended up in many different sort of types of therapy and 12-step groups and explorations about myself. And now it's kind of 17 years later. I've been abstinent for 11 of those years. So you can tell it took me a while to get abstinent. But what inspired me to work in this field is that in the early times of my recovery, I knew that there was something quite meaningful to this for me. And I started training as a counselor and then as a coach, and then doing more counseling training ever since, but straight away as soon as I got into recovery. So didn't see clients for much later, but I was already training, which helped me in my own self-discovery as well.
Right.
So yeah, that's how I got into it. It was just inspired essentially by my own experience, first with addiction. And then, of course, as we get into addiction recovery, the trauma comes out. And so then I got into trauma recovery. And then I started doing more study to kind of, pivot from just coaching and basic recovery counseling and coaching to also doing that trauma therapy work.
Wonderful. Thank you for sharing that. So it sounds like, some of your early counselors, maybe you weren't that informed or that helpful. You went down a rabbit hole. At what point did you actually realize it was food addiction, or kind of perceive it as such, as opposed to just saying, okay, this is emotional overeating, or this is an eating disorder? Like, when did you actually have the language about it, or like perception about this framework?
That's a really great and important question, actually, because I was in OA for about 5 years. And back then we were calling ourselves compulsive overeaters, mainly, really. And the counselors that I went to see were all about eating disorders. And so there wasn't really anyone who was mentioning that term. And I do remember distinctly somewhere in a 12-step meeting somebody identifying as a food addict. And I just really loved that label and somehow followed that person through a maze of Overeaters Anonymous meetings to meetings that were more explicit about the term food addiction. What actually helped me to get abstinent is that identification with addiction. And specifically for me, what really got me abstinent was not just the sort of more vague guidelines of, have 3 meals a day, nothing in between, or just have, moderate meals. It was difficult for me to achieve abstinence with that. And what helped me was that sort of approach of, okay, I've got a volume addiction as well. So I need to weigh and measure as well as let go of my trigger foods. And that really turned it around for me. And there were many moments of desperation, which I think in a way are now a blessing, because I think that desperation is why I've got such good recovery now, is that it was like, I cannot ever go back there. It was so, I think I wouldn't survive it. I really believe that. So yeah, thank you.
And like the volume addiction, is that again from OA, or where did you pick that up?
Yeah, that was so in the maze of the 12-step world, there are meetings which are 12-step meetings, and there are meetings which are HOW meetings. HOW's HOW stands for honesty, openness, and willingness. And so when I entered OA HOW, which is essentially those, whatever 12-step group you're in, because there are many 12-step groups for many addictions. When you go into a HOW branch, it's more sort of specific, more rigid, I would say, right? And so in those HOW meetings, they were talking about weighing and measuring, and they were talking about volume addiction. And that's where I picked that up. And that was a real eye-opener, because it just helped me. It's not for everyone, but it helped me a whole lot, because I felt that in my early days of understanding that I've got an addiction, the clear guidelines and the kind of structure was incredibly important. Just that it was very black and white, but I needed it at that time.
And do you feel it now? How is your structure? Are you still as structured as you were, or do you feel like over time the need has lessened, or is that structure is still necessary for your recovery and abstinence?
Yes, the structure has not left me. I need the structure. So I do weigh and measure, and I do
Oh,
still obviously not eat my binge foods, whatever
yeah.
they are. So I do sometimes not weigh and measure. So say I go out, or say I'm, on a holiday. Recently I
Hmm.
was on a retreat, and it involved some not weighing and measuring and during that time. And usually what happens is my mental health declines so rapidly, and
Hmm.
I don't understand. It's not a cognitive, but it's a physiological kind of inability to understand what's happening in my body in terms of fullness and hunger and what my body needs essentially. And I do believe for me personally that is
Hmm.
wiring. It's and the way that I explain it to people sometimes is because people see me eat and they see that I weigh and measure, they see my little Tupperware, and they're like, so why do you do that? And I explain and I say, it's like this. Say you're somebody with a walking disability, like say you need a stick or a wheelchair, right? Whenever you go for a walk to a national park or something like that, you're always going to check whether or not you can walk on certain paths that are wheelchair accessible or which ones you can't walk on. If there's like this massive nature trek, you're not going to go on that because
Hmm.
you don't have that ability, but you've got the tool, which is your wheelchair, to be able to go on that path. So you're not missing out on the experience, right? So I say that's what I do with food. I do not have the ability. I don't, I feel like it's a disability, and I'm totally happy with that term, even though I know for some people that would be stigmatizing. I feel totally fine with knowing that I need to weigh and measure to maintain my peace of mind around food and give my body what it needs to be just right in terms of fullness or hunger, right? And I've worked with various health professionals to really have a nuanced food plan around what I need. And then every once in a while, that food plan has to change. So recently, I've had to change things a bit because of menopause. And so things just shift, and that's okay, right? But I do work with people who help me do that because I still see the need for that structure. And I say still, but I also know that a lot of people in long-term recovery who might be in their 60s or 70s, they've done this for 30 or 40 years, and this is just what works for them. So this
Hmm.
works for me.
I love that. I think you're just such an amazing role model in the way that you speak. It's just seems really empowered and confident. And I think that there is sadly a lot of stigma in society around weighing and measuring, like it's perceived as being in an inferior way of being, like it's less embodied or something. But I see you saying, no, I feel great. This is my way of achieving
Mm,
my best life. Like this is my path to embodiment, is like weighing and measuring, and this is how I feel good. And I'm
yeah.
really curious how you were saying if things do need to arise, I think that this is a great learning opportunity or modeling opportunity for people. What were the symptoms or like experiences that indicated to you that you needed to change? And then how did you make those changes? Like, was it cravings? Was it feeling like overly full or overly hungry? And then did you work with like a nutritionist in your area? How did you make these changes so that other people who might be listening, who might feel like, oh my gosh, I'm stuck in this meal plan forever, how can they make changes in the future if that happens for them too?
Yeah. You mean the recent changes, right? When I recently changed my, yes, yeah.
Hmm.
Yeah, that's again a great question, which is not often addressed, really, right? Because we sort of say, I work with people and we do this, but what do we actually do? So yes, let me explain that. So what was happening for me is I was noticing that my digestion was getting a lot worse, which has always been a thing for me, but menopause just put that up a notch basically. And so I felt that I could no longer digest things that I was previously able to digest, and a lot of things changed. So I went back to a health practitioner that I'd been to before. I also then eventually found another one, and these both people were working in the space of Ayurveda. So I'm actually, it's a little bit different from, often you hear people talk about keto, low carb. These are
Hmm.
great
Right.
things. For me, for some reason, Ayurveda really resonates because it's cooked food, it's very heartwarming. I can't digest raw food very well. I
Mm-hmm.
also don't do, my digestion doesn't do well on keto. So I knew that that was the path. And so I essentially worked with somebody on this. And usually what happens is when I work with somebody new, this was an Ayurvedic health professional. So they're sort of like Ayurvedic doctors. So, they kind of give advice on nutrition, supplements,
Mm-hmm.
nervous system regulation, those types of things. Usually when I work with somebody new, I have to educate them about food addiction, right? Because they will say, well, you could just have a little bit of this only sometimes. And I say, look, for me, like, you've got to be really specific. How much of what should I have when? And like, can it be every day? Or if not every day, then can it be 3 times a week? And that's how I work, because I need the structure, right? I just have that. And I really honestly believe it's not a psychological thing. It's a form of neurodivergence for me.
I was
That's
just
my
about to,
experience.
I
Yeah.
literally was just about to ask you, I was like, do you
Yeah.
identify as neurodivergent as well? And it's like our mind just works
Yes.
differently.
Yes. And I say that because I don't have any sort of neurodivergent diagnoses, but I firmly believe my lived experience of addiction and complex trauma is that I'm neurodivergent because of those two conditions, even though I might not be autistic, maybe I don't have ADHD or whatever else there is. But I firmly believe that addiction, in my case, because I've had it for so long or forever, maybe it's a neurodivergent thing. It's like I can do therapy until the cows come home, but these are some structures that I need to address through lifestyle, not through therapy. It's not psychological. Yeah, I feel very strongly about that. And so ultimately that's how I changed my food plan. And also then it's about monitoring what works and what doesn't work. And I keep in touch with that professional. And importantly, I have a network of, just 2 or 3 food people who one person, for example, she used to be my sponsor in a food fellowship. Now we're sort of co-sponsoring each other. And what's important about this is, even though I'm in long-term recovery, I do not make major food decisions by myself. I always run them past my friend and I say, hey, I think I'm going to try this because my body is saying that, right? And then she's like, okay, gotcha. So it's not like I'm asking for permission. It's more like I'm running it past you because I need to keep it all out in the open. Having addiction, right? I need to be sure that my mind is checked with somebody else, because the nature of addiction is that sometimes we find ourselves in an addictive loop and we don't even know that we're in one.
So were they the ones who proposed the quantities as well, or was that something that you created
Mm-hmm.
along with your friend, or like where was the quantities? Like who
Mm-hmm.
created that part?
So initially, this many years ago when I first started this, they created the quantity for me, and then I tried it out and I reported back on how that was going in terms of hunger or fullness and whatever else, digestion. And then I would say, I think I need a little bit more, or I think I try a little bit less, or whatever. And then it just was very nuanced for me. And it went, and which is why it was so important to have an ongoing relationship with somebody. And then more recently, when I had to change the plan, it was a case of almost like a collaboration. It was like they'll say one thing and I'll say, oh, hang on. So shall I try? Can I try that? And they'll go, yeah, okay, you can try that. And so, for example, once recently, I was advised I should drink, buttermilk occasionally for my gut. That's one of those things that Ayurveda offers, And I was like, but how much and when, right? Because I can't just sort of, because if I don't have boundaries around that, I will just make that mean that I can drink buttermilk from morning to night and it'll be 3 liters a day. Literally, that's where I will go
Hmm.
with my
Hmm.
addiction. So I
Hmm.
need to co-create this. And so where my friend comes in is I kind of run that past her, what I discussed with the health professional. She won't comment in terms of, oh no, but you should be doing that. She'll go, okay, gotcha. Let's see how that works for you. And then so I've got a 3-way kind of system almost, which it all sounds pretty elaborate, but it's the simplest and most wonderful thing that it's just part of my life. Yeah, it's fine. There's no burden to it. It's just great that I have that.
That's wonderful. And it sounds like you have a lot of support too. Nothing wrong with
Mm-hmm.
that. I want to ask you about your perspective on recovery and abstinence. You said that you've been abstinent for like 11 years, and you had mentioned you've been on this recovery journey for a long time. And I'm curious what your perspective is. I know that you come from an OA or it seems like a 12-step type of background where abstinence might be the first step, and then recovery is like a larger journey that's where abstinence is the first step. But I'm just curious if that's your perspective, or is like, does recovery come first and abstinence maybe doesn't have to be a part of it? Maybe sometimes you're abstinent, maybe sometimes you're not, you're still in recovery. I'm just curious if you can elaborate on what your perspective is on what recovery is and what abstinence is, and if they're related, and the order, anything you want to share about that.
Yeah, absolutely. Definitely there is that school of thought, right? That you've got to be abstinent and then you work the steps and that's your recovery. So in my experience, it's really not that straightforward. It would be counterproductive to have to be abstinent before you start working the steps or before you enter some sort of recovery, even if you're not doing 12-step, but some sort of recovery. I mean, luckily the 12-step programs, they are welcoming of that. They say, you're the only requirement to join this fellowship is to, have the desire to abstain or whatever, right? In my personal experience, what happened is I was actually doing harm reduction for myself without having the terminology of harm reduction. But what I was doing is I was slowly replacing ultra processed foods with fruit and vegetables. So I was still volume eating. I was eating, at some point, I was eating that many carrots that I turned orange. So, I was volume eating, but I was replacing those foods with other foods. And that helped me. I wasn't conscious that I was doing that, but essentially I was doing that. It's almost like my journey got refined over time. I don't think I would have been able to go abstinent and cold turkey on all of those things all at once. I tried though, but I just couldn't do it. I couldn't stick with it. And so I got very demoralized. And what kept me in recovery was just the community and keep going back and keep, like engaging with the broader mission of recovery as opposed to just what am I actually eating. Now I see that with clients as well, is that, there's a couple of people that come to mind where it takes sometimes a couple of years of doing work one-on-one or in some kind of a recovery environment where people come to the conclusion, okay, this has been my journey. I've tried to moderate, but I have to go abstinent, right? Some people are very clear on that from the start. So I don't prescribe anything to clients in that regard. I don't, I'm just very open to, okay, here's somebody who really is struggling. Here is somebody who really would like to recover, but there are blockages, there are concerns, there are fears, and there is a lack of skills and knowledge sometimes. And so we've got to meet people where they're at. And so certainly I also have seen, and I'm so humbled by this, I've seen clients who can moderate things that I can't. That's totally cool. That I'm not them, right? They're a different person. And this is where the individuality comes in, I think, and the nuanced treatment that we talk about often in this space. I wouldn't be prescribing, like a particular food plan or method to anyone. I think we've got to meet people where they're at, and then we work it out based on trial and error, and it's their individual journey. So yeah, I'm all for harm reduction, abstinent, whatever your journey is, make it your own.
One of the things I was really attracted to was just all the different methods and modalities that you bring. So you have such an integrative approach that I don't know if I've seen this elsewhere. Someone who specializes in food addiction and internal family systems and somatic approaches and mindfulness. How do you choose, like, when you're working with someone, when does IFS come out? Like, when does the somatic approach come out? When does a mindfulness approach come out? Like, all these different modalities that you have, like, what influences your selection in working with someone?
Ultimately, it's all guided by being a person-centered therapist. And so when we are person-centered, it means that, it's about the person and where they're at. So it's so highly individualized. And so when I have an intake session with a client, I usually, by the end of it, we have a sense of, well, where would we like to go, right? We can go here or we can go there. What's the priority? Sometimes it takes more than one session, might be 2 or 3 sessions, and then we've got a bit of a richer picture. And we kind of agree. And so usually what happens is, this is a bit of a generalization, but often what happens is somebody comes in, and if they're in acute addiction and they come in and they're like, I just have to get this binging under control, or I've been struggling with this for decades and I can't get this right, and I'm just distraught. And there's usually some sort of a moment that made them realize this, and that's why they come now, right? There's always that question, well, why now? And they're somehow very desperate to change their addictive behavior because it's very destructive for them. Then I usually propose that we might go into sort of the lane of being a little bit more practically focused for the beginning. So what I mean by that is we look at, the kinds of nuts and bolts of the nature of the addiction. Well, what is triggering me? What sort of situations, what types of foods or food substances that are triggering me, what kinds of behavior situations, the very kind of standard stuff that we would do in addiction counseling. And this involves things like cognitive behavioral therapy or DBT. Once we get into, once I know what my triggers are, and once I understand, okay, I've been using food to cope with these triggers, to navigate those types of situations in life, then we usually get to a point where we think, okay, well, what new skills do I need to learn? What kind of new activities do I need to schedule? Or even the fact that I need to kind of have a bit more of a structure. How do I change my life? How do I change my lifestyle to accommodate this addiction, this recovery journey that I'm now on, right? And so often DBT comes in because we think, well, how do we deal with distress intolerance? How do we become more emotionally regulated? What are some of the skills of dealing with our emotions that we might have not had before? We might have not even ever been able to name what we're feeling, let alone regulate our emotions. And so it sort of takes a bit of a route of, okay, well, what is missing for the client? And then I go, okay, well, what could happen next? So more recently, for example, it transpired with a client that she was realizing there were certain triggers, right? And one of the things that she pinpointed, which is so typical, is that she was just gulping down her food and she was just eating so fast, and she's never eaten in a slow way. So then I shifted to, okay, well, let's do some mindfulness here, right? How can we become mindful of the moment of, having the meal and what leads up to the meal? And do I even know how my body is feeling before the meal, during and after the meal? So it's a very organic process. So even though I've got a bit of, in my own mind, I might have a bit of a structure of the kinds of components that I might find are important in recovery, I will pull them out, like whenever I think that might be helpful. But there are other scenarios as well, which are entirely different, where, internal family systems might come in first because people are more interested in resolving some of the inner conflict that they have around, I want to give this up, but no, actually, this part says it's not okay to give this up. And there's all this war going on, or there is trauma, which is so acute and sort of comes out that we need to deal with the trauma first before we even look at any changes that could be made, because making any sort of changes doesn't feel safe in that regard. And so it's very individual, but a typical thing could be that, somebody might come in with an acute addiction. We look at things in quite a practical way together, and then eventually shift into deeper emotional work, because the emotional kind of underlying issues then often come out.
Definitely, that sounds like a good progression. The IFS in particular, I think, sounds like an amazing support for someone dealing with food addiction or eating disorders or any sort of struggle, but particularly as it relates to food addiction, that's a pretty revolutionary support. And I wonder if you could explain a little bit more about internal family systems therapy model and how it could apply to treating food addiction or eating disorders.
Absolutely. Yeah, I'd love to actually give you an example of how it might apply to binge eating disorder and food addiction, because there is that murky waters between the two. And like, I think this could make it a little bit clearer for me, at least. IFS basically is so internal family systems. Nowadays, everybody knows him. Dr. Richard Schwartz invented it. He's so famous now, but wasn't back then. But he basically, is a family therapist and realized, okay, well, it's not only the system of the actual family, there are also systems inside a person, like people seem to have parts. So what is that all about? So he kind of experimented with that. Interestingly, with people with eating disorders, that's where it all started. And so the main premise of IFS is that the mind is multiple, and that is totally natural. So what that means is we all have parts, which, are like sub-personalities. They've got their own sort of roles, their own thoughts, feelings, behaviors. And then we also have a self, which is not a part. It's more like a sort of wise and compassionate kind of center of a person. And so in an ideal system, because when we talk about IFS, we talk about ourselves as a system. In an ideal system, there is a balance whereby self kind of leads or drives the bus, let's say, right? And the parts are kind of just there and supporting the system in whatever way is best. When, however, we grow up in ways which are not always optimal, parts might take on protective roles, right? They might take on extreme jobs because they sort of think they need to protect in some way because something has happened that has made them believe that or understand that. So that's how systems can get out of balance very easily, and most of us have that. No, it's not that you need to have an extreme trauma history. Most of us have those different parts, and so ultimately IFS puts parts into different categories. There are managers and there are firefighters, and those are parts that are protective parts. So they essentially use different strategies to protect the system and to protect more vulnerable parts, which are called exiles. Exiles are essentially wounded parts. Often they are young parts. They carry maybe shame or fear or painful emotions that are sort of that we tend to shut away, right? The managers and firefighters are the parts that shut them away. They exile them because they don't want any imbalances in the system. So if there's lots of sadness or anger or anxiety, they might go, well, I'm just going to push them away. I'm not going to cry. I'm going to make sure Vanessa is not going to cry. She's not going to show her feelings, or she's going to be a people pleaser. So we sort of have all these tasks that come in and operate with certain strategies. So managers, for example, typically are more organized, more planning. They're concerned with functioning well. Inner critics are managers. Exercisers or workers, those are all managers. Planners, dieters, wanting to control weight. There's a lot of control involved. Firefighters, on the other hand, are known to be parts that just literally come in like a fireman, and they sort of like extinguish the flames of emotional pain, and they don't care about any consequences. They just sort of go, okay, I need to stop this now. What am I going to do? I'm going to have a binge. I'm going to self-harm. I'm going to have an angry outburst, right? So those are the kinds of more impulsive parts. And then, like I said, we have those exiles, which are those kind of often very shut away, hidden, suppressed, wounded parts. So how does that work with eating disorders? So more generally, I think where this adds a lot of value is that, in eating disorders treatment, often people do formulations, which is like you kind of look at, well, what behavior starts first? There's this, and then there's that, and then there's that. And so it's very much in the language of pathology. I'm concerned about my weight, so therefore I restrict, and then I start binging. This is the very typical eating disorders kind of formulation. So when we do it with IFS, we can still do a formulation, but it's more of a process of compassionately looking and creating a map of, well, which parts of me are involved in this kind of system of the eating disorder or of the food addiction, right? What's actually happening here? There's a part of me that feels like they need to binge because there is, a difficult emotion or something like that. And then as soon as that part has done its binging, the inner critic jumps in, and that triggers an exile of shame, right? So we can see, the sort of the cycle of what happens in the process. I think what also then IFS does, it can go a step further and work with the exiles. So those are the wounds, the childhood wounds, essentially. Heal those wounds by being with those young parts and essentially establishing a relationship between the self of the client and the part. And so the more we have those secure inner relationships, the more those younger parts will feel that they can trust us, that we can support them and that we can bring them back into the present. We can unburden them and bring them back into the present. And then there's more of an integration. And when that happens, the protectors, the managers, the firefighters, they will see that happen and they go, well, I think it feels safer to not have to do that big protective job anymore. So that's how healing happens in IFS. And this is where I come to the example, because this is, I think, which really illustrates this is the binge eating disorder versus a food addiction, right? So a typical thing that might happen in binge eating disorder with a client is that they have, like a manager who wants to restrict food, they want to maintain control. There is a firefighter that's doing the binge eating. Maybe that's in response to stress or something like that in life, right? And somewhere there is an exile as well underneath that, which needs healing, right? Needs to be worked with. So if we develop trust over time with those protective parts, like the firefighter, the binging part, the controlling managers, then eventually we can access the exile and we can do those healing steps. We can do what they call the healing steps, the unburdening in IFS, and it leads to more internal kind of safety and less burdening internally. When that happens for somebody who has binge eating disorder, and I'm generalizing, right? And it's also not a quick fix. So I want to say this is not one session. This is usually, a bit of time. This is psychotherapy, right? When we can achieve that healing over time, that person may be able to then moderate all foods, because the food wasn't really the issue. It was the wound underneath the food that gave rise to the firefighter having to do a big job of binging all the time to keep that down, right? To support that in some way. Now, all of that applies to food addiction as well, except that you can do all of this healing with IFS, but somebody with a food addiction there's a biological component to it, which means that they will still might find that they have to abstain from certain foods. They will be more like somebody with an alcohol addiction, right? They will not be able to just have that one beer or wine or whatever, even though their wounds have been healed. There is still that need for having a certain structure around food, which involves lifestyle changes, which is nothing to do with therapy. Does that make sense?
Mm-hmm.
Yeah.
I love that example. Thank you so much for expounding on that. And I love that you said that the processes would be the same, except for that even with healing, that they still might need to abstain from certain foods.
That's right, absolutely. So there is just that subtle difference, and so in binge eating disorder, you might then support a client by saying, all foods are fine and that's not a problem and don't worry about the food, moderation is fine. And sometimes that just doesn't work for the person who's got that food addiction. So we just need to almost go a step further there sometimes. Yeah.
One last question I have for you. You said in your practice that, you work with all sorts of individuals. You said some people come in more of an acute state and they just feel like, I just need to stop this mad binging right now. And then maybe other people are just trying to figure out the conflict and get a little bit of relief. I'm wondering if there's people, how many people come to you for wanting to lose weight, if that's a thing in your practice.
That's an important question. And again, especially in the space of eating disorders, that would not be a desirable goal often, like when we talk about weight loss. Often people come in because they are worried about their weight, for sure, with food addiction. And often there are people who are of a higher weight and they are worried about, maybe the doctor has told them that they need to lose weight, or they themselves feel that they need to lose weight. So yes, that does very often happen. We don't necessarily address weight directly when we work together. So I'm not necessarily going to say, okay, well, let's see, how much do you weigh and what are we going to aim for, right?
How many calories do you eat?
Yeah, no. So it's not like that at all. It's more about shifting the focus off the weight into, the broader area of recovery, helping people to make lifestyle changes, building a support network, building better habits, and supporting them in whatever they need support with to possibly then for the weight loss to come as a byproduct over time, right? That's a scenario that does happen. Other times there are people who also have eating disorders, and they, sometimes they might feel that they're overweight, but they might not, they might be of a sort of, and again, I'm generalizing, that might be of a normal size. Not that I assess that, but if you were to kind of look at
Yeah.
that subjectively, I suppose,
Mhm.
they're more than concerned about their shape, their size, their appearance, as often is the case with eating disorders. So then you kind of, you can use IFS to kind of look at, well, why is that so critical, so important? What parts are involved here to make that such an important part of your experience? I also have clients who are on GLP-1s, or have had bariatric surgery or are considering them. And so then again, there is a kind of piece of work sometimes that we can do in terms of, well, what motivates that? What parts motivate that? Are you feeling okay with taking these medications? What parts are on board? Which ones aren't? What about the surgery? So we kind of, more look at the underlying things as opposed to the thing itself, because I'm obviously not a medical professional, right? So my ideal scenario is that they work with, a GP or somebody in that space who they already have that expertise, and we can look at the deeper layers that are not often discussed in the doctor's office.
Thank you so much for sharing. You have been just so great today. Thank you for sharing everything. It's been really illuminating. If people want to find out more about you, what's the best way?
Yeah, easy. I have a website, vanessakredler.com, and you can find everything I do there and get in touch with me there. And it's always lovely to hear from people. So yes,
Okay.
website is the best place.
Okay, we'll be sure to leave the link in the episode description. Thank you so much,
Mhm.
Vanessa.
Thank you.